Good afternoon, everyone, and welcome to today's Pioneer Institute briefing on the patient cost of Copay Accumulator and Maximizer programs. I'm Jason Harris, Vice President of Government Relations and Advocacy for the National Psoriasis Foundation. NPF is the leading national nonprofit organization supporting research on psoriasis and psoriatic arthritis and advocating for the needs of the psoriatic disease community. Wouldn't be right if I didn't give you a quick primer. If you didn't know about psoriatic disease, it's a heterogeneous immune-mediated condition, affects over 8 million Americans, primarily affecting the skin, but most patients do have evidence of systemic inflammation, which increases their risk for the development of multiple chronic conditions, which is important, and we'll get to obviously the topics of the webinar in a little bit. But when we think about individuals living with chronic diseases and disabilities and having to afford different medications, the Copay Accumulator programs really do harm folks. I'd like to thank the Pioneer Institute for organizing this event and their leadership in researching policies and programs that impact patient access and treatment affordability, especially for those living with psoriatic disease and other complex and chronic conditions. On behalf of the Pioneer Institute, I'd like to give a huge thank you to our guest speakers who are with us today. We're going to provide their perspective on the patient impact of these harmful programs and a recent Pioneer Institute white paper that examines the impact of Copay Accumulator and Maximizer programs. And lastly, I want to thank all of you, our live and on-demand viewers, for taking the time to learn how individuals are being impacted by Accumulator and Maximizer policies and how we can better protect everyone, especially individuals living with chronic diseases and disabilities. There will be an opportunity to engage in the discussion with our panelists and ask questions at the end of today's program. So in the next hour, we're going to be hearing from several healthcare policy and advocacy experts about the impact of Copay Accumulator and Maximizer programs. They include Tammy Soretti, an advocate with the National Psoriasis Foundation and our Eastern Advocacy Network co-chair, Dr. Bill Smith of the Pioneer Institute, Dr. Wayne Weigarten of the Pacific Research Institute, and Dr. Robert Popovian of the Pioneer Institute. Thank you all for taking your time to provide your expertise and share your ideas. So before we get going with the experts, I just want to do a quick level set and remind folks why we're here. And I'm going to use our community, the psoriatic disease community, as an example. So over the last 20 years, our community has seen firsthand how science, scientific advancements, and innovation have truly changed the lives of people living with psoriasis and psoriatic arthritis. Highly effective treatments in the form of biologics have improved the lives of millions, leading to improved quality of life, work productivity, just better, more fulfilling lives. And now that we're closer than ever, which we really do feel, ever to cures, remissions, and disease management therapies that we strive towards for decades, it's all for naught, though, if anyone who's prescribed a treatment is denied access or can't afford it. So what we're here to talk about today is insurers and pharmacy benefit managers, or PBMs, as you've likely heard, have designed accumulator policies that bar manufacturer-provided copay assistance from counting towards an individual's deductible or out-of-pocket maximum. So we know individuals with chronic diseases heavily rely on these assistance programs to access their prescriptions, especially where no alternative exists. And we know that adherence is impacted by treatment costs. In fact, about 70% of individuals will abandon their treatment when their out-of-pocket exceeds just $250. So the implications of these practices on patient access to treatments are truly significant. Insurers and PBMs are targeting individuals living with chronic conditions, disproportionately impacting folks from underserved communities of color, and again, those with conditions that do not offer a generic equivalent. In fact, as you'll hear a little bit more today, a new Pioneer Institute white paper found that Copay Maximizer programs could potentially increase medical costs by $1.3 to $2.5 billion. Now, the good news, why we're all here today, is that policymakers are taking notice. We've seen a number of states across the country that have taken action to ban these practices, and there's federal legislation in both the House and Senate this Congress, the HELP Copays Act, that would do so across the country. So a really important and timely issue, and we're excited to dig in here. Before we get going, just a few friendly reminders for everyone who's attending live. Everyone on today's webinar is in listen-only mode, but you can use the Zoom chat Q&A feature to submit any questions to our presenters during the discussion. Again, we will have time at the end of discussion for a Q&A answer session. Now with that, let's get started. So our first presenter, I'm really proud to introduce, is Tammy Soretti, who's an absolute rock star as a patient advocate for the National Psoriasis Foundation. We are really proud to work with her. She chairs our Eastern Advocacy Committee and is truly an integral part of our advocacy community. She also is an active member of our one-to-one mentor program, which connects people with psoriasis and psoriatic arthritis with others in the community who are thriving to form lasting relationships. So thank you for being here, Tammy. Can't wait to hear your presentation and your story and the importance of advocacy. All you, Tammy.
Thank you so much, Jason. And thank you guys. Thank you all for having me. And thank you who are coming and listening. I'm kind of used to giving my elevator speech, which is very abbreviated. So I'm going to give a little bit longer with my very first PowerPoint presentation today. So bear with me. Again, my name is Tammy Soretti. I am from a suburb outside of Pittsburgh. Proud Yinzer and fluent Pittsburghese speaker. And I wanted to show you real quick before I start my slide presentation. This is me before my current treatment. So I just wanted to show you that since I can't show it during the slide presentation. Now we're going to try this and see how it works. And we're going to try this little button here. There we go. Okay, I was diagnosed with psoriasis in 1996. Being diagnosed with psoriasis is easy, because it's very visible. It's very unique looking. I was diagnosed with psoriatic arthritis in 2008, which is nothing like being diagnosed with psoriasis. It took years. I mean, 9 years I was having symptoms and not knowing it. I have a comorbid condition that I get called enthesitis, and I kept having terrible pains in my fingers, in my thumbs, in my ankles, in my feet, where I couldn't get out of bed. Was literally crawling up and down my stairs. I had my own business that I was the sole proprietor of, and it was very labor intensive as far as hands. I did deliveries. I had to close it down because I simply physically could not do it anymore. Not only did I have to close it down, I couldn't sell it. So I went to work for my dermatologist for a year to pay off my business loan. During that time, he grabbed my hand one day and said, "You need to get to a rheumatologist. You have psoriatic arthritis. You need to get this taken care of now." So I did. And they gave me treatments. I did everything I was supposed to. The doctors did everything they were supposed to. I failed 7 biologics in 11 years. I failed 3 oral treatments, which I was taking cyclosporin and a biologic, and ended up in the hospital with an ear infection for 3 nights, but still had psoriasis. In 2019, I became the anomaly, and I went on an oral medication that at the time they were like, yeah, it probably won't work. It probably won't do this. It probably won't, it'll take a really long time. And within 2 weeks, my hair started growing back. Since August of 2019, I've had no new joint damage, and my psoriasis is down to about 15% coverage from about 85%. If you see today, I have a headphone on. That's because I get psoriasis and have psoriasis today in my ears. I did have very pretty earrings to wear, but today's no earring day, and I can't wear earbuds or anything like that, which is kind of a bummer, but it's a small price to pay. I've had a lot of spinal damage just due to the time that it took to get diagnosed, the time that it took to find an effective treatment. Psoriatic arthritis damage can happen really fast. So I have joint damage in my spine, in my cervical spine, in my lumbar spine, and in my SI joint. And what they do with that, I go in about every year, year and a half, and they just go down the list and they do what's called a radio frequency ablation, which they burn off the small nerves around the joint so that I can't feel the pain. It's temporary, but it's effective. I have had replacement of the joints in the base of both of my thumbs. It's called a CMC arthroplasty with LRTI, where they take a bone out of my wrist and replace it with a tendon. And I had both of those done within 2 months because I was waiting to start my 7th biologic. Let me say that it is not for the weak. It is not easy. It is not easy to go around with no hair. It is not easy to go around covered in psoriasis. People will happily tell you that you have something in your ears, you have something in your hair. How can you go out like this? You look gross. How can you be seen in public? It's very damaging, not only physically, but also emotionally. And because there's no test yet for psoriatic arthritis, you go through a lot of misdiagnoses, a lot of people telling you that, your pain is not what you claim. You're a hypochondriac. This is all in your head. Maybe it's tied to your cycle. All kinds of crazy stuff. And because of all of that, I became very isolated, and just became a little bit more hermit. I lost some friends because I was deemed unreliable, when actually what it was my psoriasis was so bad I couldn't get dressed. And I spent a lot of time sitting in my room or sitting on the couch. So when I found the National Psoriasis Foundation, it opened up an awful lot of doors for me. My first thing that I went to with them, I was just hanging along the wall, and people came up and started talking to me, and I realized people were telling my story. I now have a huge family of people with psoriatic disease that I can call or text or email at any time, day or night, and they are right there. And through the National Psoriasis Foundation, I found out that I had a very unexpected, for an introvert, passion for advocacy. I love advocating. As Jason said, I'm a one-to-one peer mentor for people newly diagnosed with psoriatic disease. And I also have become a fundraiser. I had 4 of them before COVID and did pretty good. Now I'm going to try to change this screen to the next one. We're going to see how this goes. Okay, so what has happened the last few years? When I went on this medication, my copay for this medication was $35 a month, and that was paid by my copay assistants. And at that time, I was like, I told them I don't really need copay assistance because it's $35 a month. I can afford that. And they were like, you really want this now in case something changes. Well, thank goodness they did, because this was in August of 2019. And in December of 2019, I got a letter that my copay was going up to $250 a month. Was no longer going towards my deductible. And this was still okay because I get $9,000 a year in copay assistance. Now I'm on disability. So although my husband has a good job and my insurance is through him, I have a very limited income of my own to pay for my medicine. So the $250 a month, we were good. In 2020, I got a letter that I was now going to be on a program called Save on SP, and they were going to be administrating my psoriasis medication. And that my copay was going to be $1,250 a month. So this was quite a shock. they said, don't worry about it. It's fine. We're going to cover. Once your copay assistance runs out, you have to use your copay assistance. Once your copay assistance runs out, we'll cover your copays, which they have done so far. However, there is a note on that initial letter that I got that says this can change at any time. So they took my medication off formulary. They started charging it. That was in 2020 was the last communication I had with Save on SP. So I don't even know what my copay is anymore. We don't have any pricing. We don't have anything. They can't tell me. If I call them up, they don't know. Anyways, this is a hardship. Not only, even though my medication is being covered by Save on SP, it can be stopped at any time. That is terrifying, especially this time of the year, because I just ran out of copay assistance. Although I don't know what my copay is, my copay assistance program called me this week and said, you know, you've used up your $9,000. Basically, what is happening is, like, say my car broke down and Jason said, Tammy, you know, I know you've been going through a rough time. Here's $9,000. Go buy yourself a car. So I go to the lot, I buy myself a car, I drive it home, and the next day, the car dealer calls and says, hey, you owe us $9,000. And I say, no, Jason came with me and he wrote a check for you for $9,000. And they say, but that wasn't your check. That was Jason's check. Now we need your check. And I say, well, I'll just give the car back or give Jason back his money. And they're like, no, we're keeping Jason's money, but now we need yours too. So your car, your $9,000 car just cost you $18,000. That is basically what is happening. And there's an awful lot of stress related with that, because you worry all the time. I'm constantly worried if my medication's going to get covered, if I'm going to be able to afford it next month. I can't afford that kind of money. We are to the point where my husband and I are planning on retiring out of the country just so that I can have access to my medication, and that we're the richest country in the world. I shouldn't have to move to another country just to be able to get the medication that keeps me walking. I have done an awful lot of advocacy, especially this year that we've been doing it back in person. And my main concern for all of the advocacy that we've done is getting co-sponsors and getting support for the HELP Copays Act. It will ensure that copay assistance counts toward a patient's deductible. If that $9,000 a year that copay assistance pays for me counted towards my deductible as it should and as it used to, I wouldn't be worried about this. I wouldn't be having this concern. I wouldn't be terrified all the time. My psoriasis wouldn't get worse at this time of the year. All we need is just the way that it used to be. Basically, now there's double dipping. If we could, the HELP Copays Act, which is, I got to look at this because the brain fog is bad. Senate Bill 1375 and House Rule 830 will simply close the loopholes that stop insurers and PBMs from double dipping. They're getting double the money. And if I have a surgery, if I need something else, if I'm in a car wreck, I have to pay that deductible again. Every one of my doctor's appointments, everything I do, every one of my nerve ablations, I'm paying cash because I haven't met my deductible. So this would stop that and simply, very simply, require insurance companies to put that copay assistance towards the deductible to make it affordable for all of us that have not just psoriatic arthritis and psoriasis, but any chronic illness that you're on a specialty medication, cancer, anything, you never ever know when you're going to come up against this. It could happen to anybody at any time where you're going to need a specialty medication. And this could happen to you. We are not asking an awful lot. That is all we're asking for. Thank you so much for your time. I really appreciate it.
Well, thank you, Tammy. Always appreciate hearing your story and your willingness to share your experience and your personal life with everyone to kind of bring this issue home. I think, a couple of things that hit home with me was when you were talking about the diagnosis, right? So considering the impact of these programs, even after someone has went through, a really arduous journey to get a diagnosis and then to get hit with this, it's just another, I'll call it sort of a gut punch to making sure you get the right care and can live, your best life. So you'll see in those pictures, Tammy is very active. We were really pleased to be able to get back to Capitol Hill Day this person and appreciate you coming. Okay, we got Tammy's story. And Tammy, there are a couple of questions in the Q&A I think we'll get to later on that were directed towards you. I want to move to our next presenter, who's Dr. Bill Smith, Senior Fellow and Director of the Life Sciences Initiative at the Pioneer Institute. Bill regularly conducts research and analysis on issues impacting patient access and affordability, including Copay Accumulator and Maximizer programs, ICER, and the Quality Adjusted Life Years, or QALY methodology, as well as pharmacy benefit manager practices. Most recently, Bill co-authored alongside our guest speakers, Robert Popovian and Wayne Weigarten, a new Pioneer Institute policy brief on the negative implications of Copay Accumulator and Maximizer programs on treatment access and affordability for individuals living with chronic conditions, including multiple sclerosis, cancer, and psoriatic arthritis. Prior to his time at Pioneer, Bill held senior staff positions on Capitol Hill in the White House Office of National Drug Policy. As a starting point, Bill's going to provide us with a brief background on how insurers use these accumulator and maximizer programs. Bill, we appreciate you taking the time to offer your perspective and want to give you a huge thank you to the Pioneer Institute for hosting today. And I'm going to shut up, and it's all you.
Thanks, Jason, and thanks to the National Psoriasis Foundation for participating. It's a little daunting to follow a presentation from a real live patient like Tammy did, which was fantastic and helped explain, the dilemma of out-of-pocket costs, which I believe is the real challenge for patients these days. So I'm just going to try to set the context. Wayne Weigarten is going to go into detail on how the accumulator maximizer programs actually work in real life, and then Robert Popovian is going to go into some of the policy implications of this. But at a 30,000 foot level, let me just define what accumulator maximizer programs are. They are programs designed to have PBMs confiscate. I'm not supposed to use the word steal, but I will use the word steal. All the financial assistance that's available to patients from drug manufacturers, put it in their pocket, and then require patients to still meet their out-of-pocket maximum. So none of the money available to those patients through drug manufacturer financial assistance programs counts against their out-of-pocket obligations, their deductibles, their coinsurance, and any other out-of-pocket requirements they may have. And this is not an insignificant issue, given that there's $19 billion available to patients through these financial assistance programs. And, in my view, that money could be used for two productive uses. It could be used for pharmaceutical R&D if patients didn't need to access it, or it could be used for patients so they can continue their medication, stay in the workforce. It's not a productive use of that money to put it in the pocket of a PBM. I don't see how that benefits society in any way. So let me take the PBM position and say, well, what is the justification for these programs? And there are two alleged justifications. One, we're keeping premiums low for our clients, right? We have health plans, employers, government that we represent, and we want to make sure their premiums aren't out of reach. The second justification, of course, is that drug prices are skyrocketing. They're always skyrocketing, and therefore we have to control them. And these accumulator maximizer programs are a way to control skyrocketing drug prices. Let me respond to the first. We have some experience with accumulator maximizer bans because 17 states have banned them. And The Global Healthy Living Foundation and Robert Popovian, among other authors, did a study recently where they looked at the states where those programs had been banned. And guess what they found? They found that premiums were not rising in those states. So the justification that the accumulator maximizer programs are essential to keeping premiums low looks like it's bogus. What about rising drug prices? Now, I'm gonna really go against the political narrative here and say drug prices are not rising at a significant rate. Just the opposite. I mean, there's data to suggest that drug prices for the last 5 years are either in the negative territory or completely flat. And that's due to two factors. One, PBMs are extracting deeper and deeper discounts and rebates from drug manufacturers, sometimes as much as 50% or more. And the second reason, which is not really well known, is that many drugs are going off patent. Drugs that were invented in the 80s, 90s, and 2000s, blockbuster drugs taken by millions of people, are going off patent, saving an enormous amount. I'll just use one example, Lipitor, the #1 prescribed drug in the world when it was on brand. It had 20 million people taking it. It was $4 a pill. It was an enormously costly drug. It is now atorvastatin, which is a generic drug. It costs about 4 cents a pill. Enormous savings to the healthcare system, and it flattens out the average drug prices that people are paying. So the idea that we have to control skyrocketing drug prices, I just don't agree. It's not the issue it was 20 years ago, and it certainly was an issue 20 years ago when we didn't have Part D and when many new drugs were coming in, people didn't have insurance, and drug prices were growing 10, 12% a year. That's just not the world we're living in now. So the justification for these accumulators and maximizer programs, I don't see. But I do, as Tammy pointed out, the real problem that patients are facing these days is out-of-pocket costs. It's not due to drug prices, it's due to out-of-pocket costs, which is related to how insurance benefit design is structured. And increasingly, patients find themselves in high deductible plans with hefty co-insurance requirements, particularly in the Medicare program where they can't even use financial assistance from drug manufacturers. So if you're in a high deductible plan, and God forbid you get a cancer diagnosis and you have to take an oncology drug that's going to cost $100,000, which is not uncommon for new oncology drugs these days, you're going to be paying thousands and thousands and thousands of dollars out of pocket. That's just the reality. And so out-of-pocket costs, as Tammy explained, is really the big challenge facing patients these days. There are other things that could be done with PBMs. I mean, they're not passing rebates on to patients that are uninsured, for example, when they're paying cash. There are all sorts of reforms. But in my view, reforming out-of-pocket costs and eliminating these accumulator and maximizer programs would be a good start. And again, my view, since out-of-pocket costs are the biggest challenge, these accumulator and maximizer programs are entering the market at an exquisitely bad time. Just at the time when out-of-pocket costs are the biggest challenge for patients, accumulator maximizer programs are entering the market to keep out-of-pocket costs really high. So with that, I'm going to turn it over to Wayne, who can explain in greater detail than I did how these accumulator maximizer programs work in real life and with real patients.
Thank you, Bill. Appreciate that knowledge and for joining us and sharing your perspective. I'll keep it moving so we stay on time. Next presenter this afternoon is Wayne Weigarten, Senior Fellow in Business and Economics at the Pacific Research Institute and the Director of the PRI Center for Medical Economics and Innovation. Wayne's research regularly explores the impact of fiscal policy, the healthcare industry, and drug value frameworks. He's written multiple briefs that touch on issues central to innovation and patient access and is a regular contributor to Forbes. He is also a co-author of the Pioneer Copay Brief of Focus today. Happy to have you today, Wayne, and the show is all yours.
Thanks so much, Jason. It's great to be here. I'm going to share my screen as well. As Bill said, my role really is to get into some of the details of how accumulators and maximizers are actually harming patients. It's the dry part of Tammy's story. Tammy's story was overwhelming. What we really tried to do is dig into the data look at how a typical kind of benefit design works and show how patients are getting the short end of the stick when you have these maximizers and accumulators put on top of the program. So what we did is we looked at what is the typical, hang on one second, apologize. What is the typical kind of benefit design? And so we went on to the ACA plans and looked at the average ACA silver plan. We looked at the silver plans because that's the most common plan that's purchased on the markets. And we looked at what's the deductibles, the out-of-pocket maximums, co-payments and co-insurance, all that good stuff. And that's what's on the screen right now. And you can see probably the most important number there is that out-of-pocket maximum. When you're talking about $6,400 approximately of expenditures that is capped. So no patient has to pay more if you're on the typical plan than about $6,400 a year. Now, as Tammy eloquently stated, that's a lot more than most people are able to afford, and it creates all sorts of affordability problems. But within this design, we wanted to see, well, how patients who are on these very expensive drugs, whether it's for breast cancer, we looked at multiple sclerosis or psoriatic disease, we wanted to see, well, how are patients impacted by these costs, the out-of-pocket maximums? How do patient assistance programs alleviate those costs? And then what's the impact of accumulators and maximizers? And one of the most important things when you're talking about this issue, and we're going to kind of show you the numbers behind it, is to understand that, especially with respect to maximizer programs, the benefits that are allegedly talked about with respect to the maximizer programs only exist if you only look at the cost of the drug. When you look at the patient as a whole, when you look at their whole cost they have to spend, what you realize is maximizer programs don't alleviate costs for patients. They actually impose costs on patients. So what we did is we looked at that benefit design and we said, okay, if you have psoriatic arthritis, let's say, and you're on Humira, which is a typical drug you might use for that disease, what are your costs going to be? On average, it's always difficult to get the exact price, but the cost of annual treatment is about $47,000, $47,400. And so the first row in this table that I'm showing you is how those costs would be divided over kind of annual regimen of this of the medicine. So if you're looking at it, if you have no assistance, it's $4,700 worth of costs. If you go through the co-insurance and then the co-pays and all those things, you very quickly hit the annual deductible of $6,400, $6,436 to be precise. And then in that instance, what's going to happen is that the payer, or the insurer, is going to cover the rest of those costs. So they're going to spend $40,928. So that's without any assistance, no, other types of programs. That's kind of the financial state a patient on psoriatic arthritis is facing. If they're going to control all of those horrible conditions and side effects and get back their lives, they need to spend $6,400 so that their insurer will kick in their $41,000. Obviously, that's an incredible burden most people can't meet, and that's where the benefits of patient assistance comes in. When you kind of work through the benefit designs, it's very clear that, in effect, the patient assistance steps into the shoes of the patient. They cover those costs. The payer is in the exact same position. They're spending $41,000. And in effect, the patient gets their medicine that they need. And most importantly, that out-of-pocket maximum has been hit. So any other drugs that they might need, because typically there's other conditions that people will be suffering with. So any other drugs they need, their out-of-pocket maximum has been hit. Since this is a combined deductible, on the ACA, they're trying to push towards combined deductibles. Any other drug costs are covered so that your out-of-pocket costs have been covered and you're now able to get the treatment you need. Now, the accumulator programs, which was the first kind of iteration of these programs, basically what that said is exactly like Tammy said. Jason can come and give the $9,000 to the car dealership, but you know what? We're not going to count that. So what we looked at here is, well, what's the size of the typical patient assistance program? We're now looking at row 3 of the table. And for psoriatic arthritis, if you look at the typical patient assistance program, it's $15,000. Apparently, we're more generous than what that Tammy's program was, because that assistance was even lower. But the point is, since the drug cost is the same, when you have these accumulated programs in play, they drain the entire patient assistance funds. So if there's $15,000, that whole $15,000 gets taken up by the payer, but the patient's still on the hook for all of their costs. So when you go through their copays and coinsurance and deductibles and all of those that they have to pay, they hit their out-of-pocket maximum at $64.36. But now you can see that in effect, that $15,000 has not gone to the benefit of the patient. That $15,000 is now gone to the benefit of the payer. And so the payer's cost dropped from about $41,000 to about $26,000. Now, maximizer programs, because as you can imagine, there was a lot of pushback against accumulated programs because patients would get a huge bill, right, in the middle of the year. So if you imagine the patient starts the drug in January, sometime, let's say in July or June, all of a sudden they had no copay when they went to the pharmacy. Now, all of a sudden, there's a huge bill they have to pay. And that's because the patient assistance program has been drained. That obviously led to a lot of outcry. And that's where maximizer programs come in. And I'm not going to go into the details. We really don't have time, but maximizer programs is a cute way. They save on SP is kind of part of the gamesmanship where, in effect, you get the patients to not have to meet their out-of-pocket costs with respect to the drug. And that's why in that final row where you see maximizer program, there's no cost to the patient. So in effect, with a maximizer program in place, the payer is able to drain the full value of the patient assistance to themselves. They don't take the cost from the patient, and therefore they're paying a little bit more than you would under the accumulator program, but a lot less than they would without any of these programs in place. So that seems to be okay. Well, we've held the patient harmless. And one of the things we wanted to investigate is that true? And that's where the idea that there's other costs where it matters. And that's what on this next slide we're looking at. If you're a typical patient with psoriatic arthritis, you can have medical costs in addition to drug costs. Those medical costs are about $10,400 a year. And if you had no assistance, if you had a patient assistance program helping you, or even if you were under accumulated program, you've already met your out-of-pocket maximum. So you wouldn't have to pay any of these medical costs. But under the maximizer program, you do. Now, the way these numbers work out, it's not exactly the same. It's 6409 compared to, if you looked at it, was 6436 earlier. So there's basically the same amount of money the patient pays because they have to pay their co-insurance and co-pays and things of that nature with respect to their medical costs in order to treat their disease. So the payer, in this instance, instead of having to cover the full $10,368 in medical costs, only has to cover basically $4,000, $3,959. And so when you look at these combined, and I think this is one of the real kind of contributions we were trying to make is when you look at the patient holistically, not just focus on the drug, what you see is in effect under an accumulator or maximizer program, those programs are taking funds that were meant for patients and the payers getting the benefit from it. And patients are going to still be stuck with huge medical costs, whether those costs are for drugs, whether those costs are for medical costs, whether they're for other drugs, it doesn't matter. And when you kind of work through a typical benefit design, that kind of relationship comes out. What we then did, and I'll be very quick because I know I'm running out of time and Jason's looking at me, but what we then did is we said, okay, looking at those costs, because we know from, and Jason brought this up, at $250 of out-of-pocket costs, you see a huge change in people's behavior. They don't adhere to the medications. They don't get the treatment they need. And that's at $250. We're talking about $6,400 here. So there's going to be a huge change in behavior. And so what we did is we went and looked at the literature and we kind of did the math, looking at, okay, how many people are on maximizers? And if they're on maximizers, you know, how's that going to impact their adherence and what's the cost? And what we found is when you work through that arithmetic, you'll see that in effect, because less adherence to your medication leads to higher other medical costs, not to mention the human impact of worse health. But those additional medical costs actually lead to increasing expenditures for the system. And depending upon kind of how you value those, it was between 1.2 and $2.5 billion. In other words, this program that's taking money from drug companies and giving it to insurers is actually imposing a cost somewhere between $1 to $2.5 billion on the healthcare system because we're harming adherence. And so that this isn't just a simply transfer between kind of two big corporations. What it actually is it's harming the overall healthcare system. And for that reason, it really needs policy reforms, which I'll let Robert discuss.
All right. Well, thank you, Wayne. I wasn't giving you any looks. Appreciate the knowledge there. And I think one thing before we get to Robert too is Wayne only showed two. You know, that's just for one condition. I think, you know, thinking about, I mean, our community has taught me is, you know, a lot of folks have multiple different conditions, and so if you're not reaching that out-of-pocket cap, there's a snowball effect there to costs. So our last speaker, we're going to hear from Dr. Robert Popovian, visiting health policy fellow at the Pioneer Institute, also a co-author of the recent Pioneer report that you've heard on copays. Robert is an expert on biopharmaceuticals in the healthcare industry, focusing on both clinical and policy-related economic analysis. He's published extensively on the impact of biopharmaceuticals and health policies on costs and clinical outcomes. Really appreciate having you here today, and the show is all yours.
Thank you, Jason. Thank you for everybody who has joined us today. And, you know, I'm going to make it brief because, frankly, Bill alluded to earlier in the discussion about some of the policy solutions, and actually Jason talked about it too, about some of the policy solutions that are in play right now, both on the state level and on the federal level. So on the state level, we have about 19 states that have passed what we refer to for patients as accumulator or maximizer bans. That means the state law mandates that any kind of a support has to count towards a patient's deductible or out-of-pocket maximum. So in essence, it bans maximizers and accumulators. As Bill alluded to, one of the biggest issues that comes up in the state level with regards to pushback from whether it's PCMA or the insurers, or where they sort of try to convince policymakers and employers that the premiums are going to skyrocket. The work I've done outside of Pioneer with the Global Healthy Living Foundation has shown that that's absolutely untrue. In fact, we just released an updated tool last week that it's for free. Anybody can go on the GHLF website and take a look at it, take a look at their state, and they can see that the passage of these laws in these 19 states has had zero impact on premiums, both from a graphical standpoint and visual standpoint, as well as statistical standpoint. And we keep monitoring them. And what you see is basically these laws help patients, do not impact premiums, and they're a good thing for patients to protect patients' out-of-pocket costs and these support programs, and make sure that the patient is the only one benefiting from that, it doesn't go to the bottom line of the insurers and PBMs who have created this Ponzi scheme trying to extract money from patients and just pat their profitability. The second thing is that there's a federal bill, obviously similar to what's in the state level. It's called the HELP Copays Act. And that bill is still in play. It's in Congress, and there's debate going on, active debate. You know, every committee of jurisdiction regarding healthcare has some type of a pharmacy benefit management bill, reform bill in play, and some of them have this language in there in those legislative efforts. So, and the reason that the federal law is important because, as many of you know who are listening, state laws only govern state-regulated health insurance plans. So ERISA plans are exempt from it, and that's why we need federal law. So we, being a think tank, Pioneer Institute being a prominent think tank that works on healthcare policy and specifically biopharmaceutical policy issues, Bill and I have come up with other ideas of how to sort of undermine the Ponzi scheme, as I refer to the accumulators and maximizers are. One is to, in your state, to pass anti-steering legislation. So the patients cannot be steered to a specific specialty pharmacy. The state of Texas has probably the most prominent bill that was passed 2 years ago. This allows patients to go to any specialty pharmacy that they choose to instead of going to the PBM-owned specialty pharmacy. And this is important because, as Tammy alluded to, they try to maneuver these programs like the third-party programs like Save on SP to their PBM-owned specialty pharmacy. So if the patients are allowed to go anywhere, then the whole scheme falls apart. The second thing Bill and I have talked about is that what if you are allowed to go to a specialty pharmacy, but the PBM then doesn't reimburse the pharmacy if you go to that non-PBM owned pharmacy? And there's actual legislation drafted that can mandate that the pharmacy has to be reimbursed if the patient chooses to go to them. So not only by the patient going to that pharmacy, but there's a mandate that they have to be reimbursed. And therefore, again, undercuts the scheme. And then there are other policy solutions that Bill and I have talked about extensively, and that has to do, for example, if, Tammy alluded to this Save on SP program, right? If a patient is mandated to sign up with Save on SP and to get their medication for specialty drugs for zero out-of-pocket cost, then legislation should mandate that every other product that they get should be for zero out-of-pocket costs. So it sort of like forces the issue that if you're going to make patients go through this funnel and make them go through this programs that really take advantage of them, then patients should benefit, and you should be able to pass legislation that undermines them. With that said, we're very happy at Pioneer Institute to share our thoughts with you, please let us know how we can help. But our goal is to be able to pass legislation in every state that is not yet protecting patients, and specifically also to help pass the federal legislation, which will help all patients, not just the state regulated insurers. Thank you, Jason.
Thank you, Robert. Very well said. And I think just a reminder to folks, if you have any questions, we are at the end of all of our panelists. Please use the Q&A feature in Zoom. And one thing my colleagues in the patient community would be upset with me if I didn't mention, talking about this bill, the HELP Copays Act, it really is, I was really excited and honored to be able to join Pioneer to discuss this issue, but it's really a patient-driven bill. We have a coalition called the All Copays Count Coalition, made up of many different patient organizations that are pushing this bill. I actually have a Hill Day today and tomorrow. So if you are any Hill staff, you may run into some folks coming to advocate for that bill or to talk more about it. And then, the second thing, and then we'll get to questions, is, sometimes on the Hill or everywhere we hear about the healthcare system isn't working. We need to blow it up. We need to redesign it. And I think this is a particular issue where it would be a shame if it gets lost in the shuffle, because the individual right now is the one getting hurt. And so it can have a direct impact as quickly as possible if it can get passed on a constituent's pocket. But I think that's one of those unfortunate things that occurs sometimes where, I'll call it a game between many different entities. And right now, again, the individual, that person who, the system should be designed to help, someone living with a chronic disease or probably multiple ones, is the one getting hurt. So I have a question here. I think we've gotten into some of this, but what are some of the next steps to confronting, the impact of accumulators? So we know there's some PBM reform going on, trying to attach that bill. Are there other things that you're looking at? Robert, I see you came off mute.
Yeah, the other things is, as I discussed, the direct way to address this issue is what's happening in the states, right, Jason? And then the HELP Copays Act is on the federal level, that we need to do those things. But then I would say another way getting around this is this anti-steering legislation, because as soon as you have the patient that they can go to any specialty pharmacy, the scheme falls apart, because the PBM then doesn't have any transparency of where this out-of-pocket cost is coming from. And as I said, the state of Texas passed this 2 years ago, and it's been so effective that PCMA has created a bogus coalition trying to overturn the law. in the state, because they know it completely undermines their business model that takes advantage of patients. So I would say those are the three things that we need to do. And then there's other things that Bill and I have devised that potentially can help patients.
You know, I'm going to cheat a little bit here, but Tammy, why don't you come off mute? So we know we have, you know, aside from accumulator and maximizer policies, what other practices might MPF and others be working on to get or to put guardrails around that impact folks' ability to access and afford their medicines?
Well, so glad you asked. The copay maximizers are my main thing right now, because that's something that I have not been able to overcome. Prior authorizations. I've had nightmares of prior authorizations, step therapy. I get prior authorization requirements for a generic medication that I take, for a generic NSAID that I take every day that I've been taking for over 10 years. Every 6 months, I get a prior auth for it. I've given up on medications because of step therapy. And my next to last biologic that I took went into prior authorization and stayed there for 6 months in pending. Luckily, the manufacturer was sending it to me as a trial to make sure that it worked. By the time it finally got approved, it didn't work anymore, and I wasn't even taking it anymore. So these are serious barriers to getting healthcare. They stand between me and my doctors. They stand between me and my treatment. They stand between me and my legs working, and the inflammation that shows on my skin from psoriasis, from blowing up inside and just causing more damage.
Thank you, Tammy. And Wayne, Bill, just, you know, if you wanted to add on to really appreciated kind of the analysis and some of the numbers, I think that can help bring to life sort of the problems that folks like Tammy are dealing with. But is there anything aside from this that you have your eyes on? I know one thing in particular that's popped up recently for us is kind of the alternative funding programs. Not that we need to dive, we don't have enough time to go in there, but curious what else you might be working on, or if you wanted to expand more on.
Well, I just wanted to add to what Tammy said, particularly for the benefit of Hill staff that might be listening. You know, the IRA, the Inflation Reduction Act, put all sorts of financial penalties on health plans. And for complicated reasons we could go into, it's my belief, and it's the belief of a lot of policy analysts, that you're going to see a lot more prior authorizations and a lot more step therapy and a lot more formulary exclusions in the Medicare Part D program, which you're going to start hearing from your constituents, because as Tammy laid out, this is a big problem for patients. It's standing between you and your doctor and your medication. And in my view, you're going to see a lot more of this in the Medicare Part D program in the coming years.
I'd love to make 2 points. One about the premium. And I think it is very telling that when you get rid of accumulators and maximizer programs, you don't see premiums increase. But my view has always been, if you see premiums increase, all that means is that the insurers have been taking money from people who require expensive medicines in order to give everybody else a price break. And that's almost worse. The idea, I mean, the whole point of insurance is that we all put money in so that the people who have these health risks don't have to face the full financial burden. So if premiums are going up because we're getting rid of the accumulators and maximizers, I think we need to recognize that that's a sign that you're actually abusing patients who need expensive medicines more than, oh my God, this has been a horrible thing. So I think that's something that's really important to recognize. It's great that premiums haven't gone up, but even if they do, it's still the right thing, because somebody dealing with psoriatic disease or breast cancer or multiple sclerosis, they shouldn't be spending more, so all of us pay less on premiums. So I think that's one, a really important point. In terms of alternative funding programs, you raised those, and I agree. It's complicated, it's very subtle difference, but I think when you hear about those, what you should really think is it's the same type of scheme that's a maximizer and accumulator, and for policy wonks, there's something interesting there. For human beings, it's a problem. It's something that, we need to avoid because it's the market not working. And so it's trying to gum up the works even more. So it's the same scheme, just different branding.
If I can throw something in there real quick, Wayne, exactly what you just said. When I called my insurance company about the whole save on SP and the whole thing, and I said, what is this all about? And they said, literally, we're just trying to make it affordable for everyone. And I said, well, apparently I'm no one because it's not affordable for me.
Well said, Tammy, and thank you, Robert, Tammy, Wayne, Bill. On behalf of the Pioneer Institute, I wanted to extend a big thank you to each of you and to the audience for joining us. Hopefully you found today's briefing informative. I encourage you to stay involved with Pioneer Institute on patient access innovation issues as the environment continues to evolve, which, as Bill mentioned, is certainly going to occur. Side note, every comment MPF does on IRA and Part D is about utilization management. So I just wanted to echo that our comment. And that concludes our program for today. So take care, stay engaged. If you had a question, I know there were a couple of questions that just came in. We have collected those and we'll get back to you and answer. Appreciate those comments, though, that folks made. Just had to keep us on time here. So thank you again, and we'll be in touch.
Thanks so much.
Thank you.